So, good day, attendees. Good day, everyone. Uh, so, before we get into the session, there is a note to the attendees. Attendees, you have an opportunity to interact with our speaker, and you can also get questions for your answers. And you can also get answers for your questions in the, or else you can post your questions in the chat box, or else you can raise your hand so that I will allow you to talk. So, without further delay, let's dive into the session. So, greetings and a warm welcome to everyone joining us from various concerns of the digital realm. So, today we are going to discuss about the topic management of high risk pregnancies. So, I'm glad to introduce the speaker of the day, Dr. Jyoti. So, lead consultant, obstetrician, and gynecologist. So, we welcome you, ma'am. Over to you.
Yeah, so very good afternoon to all of you, ma. Today I'm here to present a topic on high-risk pregnancy. So what exactly is high-risk pregnancy? So if anybody can interact to me and tell me, please. Anyone from the participants?
You can raise your hand so that I will allow you to talk, or else you can post your questions in the Q&A session.
Okay. So high-risk pregnancy is a term used to describe a pregnancy with increased risk of complication for both mother, fetus, or sometimes solely. This can be due to pre-existing health conditions in the mother, or it can develop during pregnancy due to various reasons, or post-delivery as well, like preeclampsia. Specialized care and monitoring in a tertiary care center is mandatory to give a possible good outcome to both mother and baby. In this presentation, we would like to highlight a few of the practical issues with the mother and the family faces during this challenging time period. So we'll start with the first implantation issues. So whenever the pregnancy gets implanted in the right place, that itself is a good news, because from where that is from where the pregnancy starts in the right, right manner. So if the pregnancy gets implanted in the tube, that is called ectopic pregnancy. Sometimes it can get implanted in the ovary as well. And that condition where it gets implanted in the ovary is again quite a difficult scenario to discuss with the couple, because you're losing the ovary, which can be related to losing the feminine hormone as well. So what are the other things which you see in the first trimester as soon as the patient gets pregnant and she thinks that's a very good news? Just one second. So this is about the scenario where the couples, they are just about to feel happy about the pregnancy, and suddenly they come to know that the uterus is, the pregnancy is not in the right place, it's an ectopic pregnancy. So diagnosis is crucial to manage any of the high risk scenario in pregnancy. So once the patient couple or the couple, they come early to you as soon as they are pregnant, we can diagnose ectopic pregnancy easily, and we can treat them with medical management. But if they are late, it will be surgical. But they're too late, then it's a life-threatening scenario. Then the other common element is vomiting in pregnancy. If you have vomiting in pregnancy, usually it is considered as normal, or you can say a reaction to the beta HCG hormone. But if the vomitings are severe enough, then we have to look into what are the other causes for vomiting, because vomiting itself can lead to a lot of problems which can be life-threatening as well. So what are the scenarios where vomiting can be life-threatening? Continuous vomiting, you're feeling dehydrated, you're feeling that you're very weak, then you should reach out to the emergency department, and we have to see whether any liver problems are there, liver function test to be done, and we have to look into whether the gallbladder stones are there or not. Then similarly, why early visit to the hospital is needed. When we do a scan, then we come to know whether molar pregnancy is there. It's a pregnancy which is fertilized, but there is no viability. There's no fetal heart, and there's no life into it. Then it becomes a difficult pregnancy to deal with, or in the sense there's no pregnancy, but the contents can be dangerous if they are prolonged for more than 10 weeks. So early diagnosis, you can prevent bleeding issues, and you can save the uterus, and you can save the mother as well. So every scenario, the early diagnosis, early intervention is mandatory. Miscarriages. There are various types of miscarriages: early miscarriage, mid-trimester miscarriages. So whatsoever the type of the miscarriage, we have to look into the psychology of the patient, and also whether they are into early miscarriage, whether we can deal with medical management or we have to deal with the surgical management. And then why the miscarriages happened is a big question to the parents. Therefore, it's very important that you know A to Z about the counseling, in the sense how to counsel this couple, whether the miscarriage can be left as it is, or we have to intensely evaluate the miscarriage, like genetic evaluation, whether we have to send the sample for karyotyping, whole exome sequencing, and all those genetic analysis are needed. If the parents, they say that we don't want to wait for any further miscarriages. Usually, if it is a first miscarriage, we don't do anything. We reassure the couple saying that 30% of the women will have miscarriage, but in the second pregnancy, in 90% of the cases, they might be fine. Then the other so therefore there is it's mandatory, or you can say that we have to create awareness about pre-pregnancy counseling, because in pre-pregnancy counseling we will see the age of the patient, the blood pressure, the diabetes, the thalassemia and sickle cell status. We'll also look into the HIV, hepatitis C status of the couple, and if they are willing. Again, social reasons are there, you cannot break them, but you have to just give an option whether they want to go for the viral screenings. So all this pre-pregnancy counseling, folic acid will prevent neural tube defects. Then B12 and D is known to help with a lot of other things in pregnancy. So all this will so pre-pregnancy counseling will help with all these scenarios. So any pre-existing disease like or condition like diabetes, high blood pressure, we can control them and then they can fall pregnant. So the morbidity or the problems are far less. Then coming to the thromboembolic event. So if anybody is having SLE, or if there is obesity or BMI of more than 40, or they had previous stroke or anything, they are called thromboembolic events. If they have any of those events, then we have to again take help of the hematologist and make a proper planning for thromboembolic prevention, and this has to be dealt with multidisciplinary team. Then again, we have to keep a note on this, that always try to see if any multidisciplinary team involvement is essential. If it is essential, don't ever hesitate to take the help of multidisciplinary team. And then coming to infections. So of late, we all have gone through a very difficult phase of facing COVID during the pandemic. And COVID in pregnancy, initial phase, we never knew how to deal with COVID. Then later we have made protocols and all. So COVID was the recent, and previously, which has been running throughout for ages, where chickenpox. Again, chickenpox is very dangerous because it can cause lung disease in the mother, and it can be difficult to treat, and it can pose a severe impact on the fetus by irreversible blindness and other problems. So therefore, very important, pre-pregnancy counseling is important so that we can vaccinate with the chickenpox viruses if the antibodies are not there. Then coming to influenza and other things, we know that there are flu shots available, but they are usually not that dreadful to the fetus, but still we should take flu shots. Then coming to people who have asthma and coming to people who have bronchitis recurrent, they should always go through, one second. Manga? And then infections. So all these things are important that we diagnose during the pre-pregnancy counseling. If not, then we have to see whether if any fever the patient had during the pregnancy, we have to look into. This could be CME or rubella, which has direct impact on the fetus. It can cause hydrops and and it can cause intrauterine death of the fetus. Then blood groups. So if the mother is rhesus negative and father is positive, and if there is any transmission happening, uteroplacental transmissions, the risk of rhesus incompatibility to the newborn can be there. It can cause hydrops and eventually demise of the baby. So therefore, everything is about detailed history, diagnosis, and reaching to a conclusion how to make a plan for this pregnancy. Uterine ruptures are rare, but still uterine ruptures do happen if the pregnancy is in the wrong place. Like if the pregnancy is in the scar area of the uterus, it can lead to rupture of the uterus, and you will not know why the patient has collapsed. So now coming to the chromosomal evaluation. Chromosomal evaluation also can lead to quite a uh, this can lead to quite a emotional, like it can lead to couples can become very I should say, they're not sure what is happening with them when the chromosomal analysis has to be done. So chromosomal analysis, we have to first start saying that chromosomal analysis is done to each and every woman. It is not specific for them. So once you tell them that it is not specific to them, they get very reassured. Anything which is specific to the couple, they get very upset about it. So tell that chromosomal analysis done universally for all to diagnose any chromosomal problems, or you can say it's screening to rule out whether they are at a higher risk of chromosomal problems or low risk. And diagnosis is further meant, what you meant by further diagnosis is if you're high risk, then we will do the Likert testing that is called amniocentesis for chromosomal analysis, cytomicroarray, or whole exome sequencing, depending upon various scenarios. So 12 weeks NT and double marker is very important. If you miss this, again, it is a blame to you because you have missed this. It's a very common universal point to be noted. Then second comes the second trimester. So what are the things which, so each and every point from implantation, post-delivery up until 2 years, you cannot say that the patient had an easy pregnancy. I tell the patients only after 1 or 2 years of your pregnancy, I can say that it was a low risk pregnancy. So my point, nowhere it's mentioned, but my point about high risk pregnancy is each and every pregnancy is high risk until 2 years. And once 2 years is done, then I will say, okay, you were low risk. Yeah. Second trimester problems are preterm labors because of most common because of infections. A patient can lead to preterm labor. That is the amniotic membrane and the uterus, they start getting very weakened because of the infective cytokines, and that can lead to preterm labors. So infection prevention, drinking plenty of water, avoiding upper respiratory infections are key for any pregnancy, and if they are diabetic, they should avoid vaginal infection. Placenta previa, abnormal placentation in the pregnancy, that is, the placenta should not be in the opening area that is called cervical os. If it is so, then it can be dangerous. If the patient goes into labor, she has to be delivered by cesarean section, and the cesarean section can be a roller coaster ride because sometimes there can be heavy bleeding which cannot be controlled, and it can lead to even cesarean hysterectomy. So all these things are about taking the patient's condition into consideration and treating her in a tertiary care center with all the facilities like blood bank, radiology facility, and cardiology, renal everything should be there. So my intention is that every woman should be delivered in a tertiary care center because you never know which of the patient can be a high risk patient. because you can feel that everything is going fine and the patient is going in for normal delivery. Or post normal delivery, patient can collapse for various reasons. So therefore, you can never say that this patient is a very low risk patient. Yeah. Gestational diabetes, again, multidisciplinary team involvement is mandatory. You have to involve an endocrinologist or a physician depending upon your setup, and make sure that her diabetes is well in control, because again, this can lead to intrauterine fetal death within 37 or 38 weeks if not appropriately managed. And here, without hesitation, it's all in the research that you have to deliver the patient early. Preeclampsia, again, it's a diagnosis. Early diagnosis can be done by the history. Suppose if the patient says that she had a history of preeclampsia in the previous pregnancy, you will start the blood thinner ecosprin. Therefore, planning of the pregnancy, pre-pregnancy counseling, planning of the pregnancy, risk factors, and how to deal with these risk factors is a plan making. So whenever the risk factors are there, it's easy to manage. But if they don't have pre-existing risk factors, it's very difficult to manage, because you have to be at the lookout of the risk factors. Then intrauterine growth restriction. To my experience, I have seen it can be due to lack of eating high calorie food itself, or it can be because of placental insufficiency or a subtle sign of preeclampsia where you have to start ecosprin. And intrauterine growth restriction can be again problematic and burden to the parents and the parents, because it can be preterm, it can be that the baby can stay in the ICU for long term. All the risk factors added to the preterm and IUGR can be infection, which can be problematic, which can be diagnosed early, and we have to see how much we can help the patient. So diagnosis is important so that we know where we are heading towards. Then amniotic fluid embolism. So as I said, just now I told you, you cannot say that this patient is a normal delivery patient and low risk, because once the delivery is done, immediately there can be collapse, which can be because of the amniotic fluid embolism. They per se, there is no major risk factors for amniotic fluid embolism. You think everything is going straight forward, but the patient can end up with amniotic, which is very difficult. You might lose the mother as well without a proper anesthesia or anesthetist and anesthesia facilities and critical care. Gestational hypertension, if the patient was having high blood pressure from the beginning, you have to look into that. Then the other factors which we look into are, without any reason also, sometimes we see that the placenta separates from the uterus. That is called placental abruption. And if the separation happens, that means the blood supply from the mother to the baby is going down tremendously. So that means there is a compromise in the oxygen supply and the fetus might die anytime. Preeclampsia, which we already discussed, and cord prolapse. So if the liquor, that the water levels are high, again, it has to be diagnosed in scan. If the water levels are high and the patient is coming in labor and the head is high, there is a high chances that the cord can come, and it's a dire emergency. Within 7-10 minutes, you have to deliver the baby. Yeah, and uterine ruptures can happen if the previous section, or you're inducing the pains with the previous scar. There can be chances of uterine rupture, which is again a emergency scenario. So, as I said, high-risk pregnancy is a retrospective term after 1 or 2 years. We cannot say that this pregnancy was low risk until everything, all 2 years or all 9 months or all 1 year has gone. It is a retrospective term. So what are the things which will help in reaching to the diagnosis that this person needs extra care or specialized monitoring? As I said, but everybody needs that. But this person who is having pre-existing, how to diagnose that? So diagnosis depends upon the blood tests, various blood tests, vitamin D levels, vitamin B12, thalassemia, sickle cell, HPLC. HPLC should be made mandatory, and like since I've been practicing, I've made it as a mandatory. and even if it is a bit expensive, I tell them don't worry about this because this is very important to get it done. And HPLC will help us in thalassemia and sickle cell prevention. So please take a note of doing HPLC to pre-pregnancy people or during the initial phase of the pregnancy. Vitamin B12, D, urine cultures, and viral screens, everything has to be done as a this thing. And if it is Rh negative, then the indirect Coombs test will be done, and always try to see what is the husband's blood group. And ultrasound imaging is essential to diagnose ectopic from ectopic till intrauterine. So the ultrasound should be the stethoscope of the obstetricians now. So I tell my stethoscope is only the ultrasound. I hardly use stethoscope until unless I don't have a physician or anybody. Amniocentesis, in any scenario, we have to diagnose chromosomal problems, or we have to do amniocentesis and send for genetic evaluation. In very rare cases, we can do whole exome sequencing to see if anything can be done to diagnose, like retinitis pigmentosa and other things, depending upon what the genetic conditions are. So again, monitoring medication, specialized prenatal care is mandatory so that you can make a plan in every visit. Therefore, it's mandatory that the women comes at least 6 times so that we assess properly, beginning from the weight of the mother till the blood pressure and everything. What is the blood pressure of the mother? What is the weight? How is the weight gain? And edema is there, whether she's having headache, how is the blood pressure and other things. Yeah. So emotional support for the mother, and if the mother is high risk, she needs a 24/7 support from the family and also from the hospital. But definitely, I don't agree that you need a phone support from the doctor. Phone support can be very tedious for the doctor as well as the, it's not easy to do any phone consultation all the time. So therefore, if there is anything, they should visit the emergency department where a nurse, supporting nurse or duty doctor can talk to them for few events. And if there is any need, then immediately the consultant should be able to reach out to the couple in the hospital. So always try to make a point that you don't use the phone calls to talk to the patient. Try ask them to come to the hospital so that you can evaluate, so that you don't miss any points. And also, we have to prevent medical legally, we should not be allowing the patients, because they might blame you tomorrow that I told the doctor that I was having pains and the doctor said just take Dolo. So therefore, never take that chance. So early identification and multidisciplinary team involvement is mandatory, and emotional wellness is very important. Therefore, try to tell the couple that this scan is done, but this is not 100%. Like suppose NT scan and double markers are done. Don't tell the patient that, you know, you will never have Down syndrome. You say that it's a low risk, but if you want more, then we can do further test called NIPT, which is a non-invasive test. Then COVID, how we have managed COVID was one of the additional risk factors which we were not used to, and we have managed very well. And mental health issues are crucial, and they have to be addressed appropriately with the involvement of the psychological counselor and psychiatrist. And also, you have, as a clinician, you have to also observe what is their social thing happening, and how is their emotional support from the husband, because domestic violence can be hidden. You have to try to make a point and see whether you think that there is some element of domestic violence. It's difficult to enter, but definitely keep an eye on. So what are the real case scenarios? I have gone through so many because I have been practicing since last 22 years. But sometimes blood pressure cannot be very simple to diagnose. So in general public, it is like, oh, it's only blood pressure and the doctor didn't diagnose. No, the eclampsia, recently, just 5 days ago, I have seen patient came with fits and the patient didn't have any symptoms of blood pressure, but very mild, 130/80, and the patient had fitted and the pregnancy was there 32 weeks. And there, if you see all the high risk factors that the patient was fitting, it was imposing a risk factor to the mother. The mother can have life-threatening problem, and baby is just 32 weeks. By the grace of this thing, everything is fine, because you have to enter as soon as possible. So never think that why to do things so early or so quickly. There's no need. No, you can save lives if you reach in time. Then postpartum hemorrhage. I'll show the video. This patient was again referred to me, and the patient had severe bleeding, and we had done all the measures to control the bleeding, and then at the end we had to do hysterectomy. Sometimes ectopic pregnancy can be with the pregnancy within the uterus also. So that is called heterotopic. That is, pregnancy is one pregnancy is in the tube and the one pregnancy is in the uterus. So you just deal with the pregnancy outside laparoscopically, and the inside pregnancy goes fine. So these patients I have seen, and they have delivered normally without any problems. Gallstones, ovarian malignancy with pregnancy, cervical cancer. This patient was coming with spotting, and nobody has done the speculum examination, and the cervical cancer was missed. So you have to make sure that you do a speculum examination gentle, without doing any pervaginal examination for anybody who is coming with spotted PV. Choriocarcinoma we have seen. So therefore, as a post-pregnancy also, you have the responsibility of seeing why she's having cough continuous, why she's bleeding. It can be choriocarcinoma. The patient was having edema of the feet, and I thought this edema is not looking right. And when we evaluated, it was nephrotic syndrome of the pregnancy, which can again be problematic. And sometimes headaches, we have to look into that. Headaches can be very problematic. And one of the patients, we have seen that she had ruptured aneurysm and she had severe problems. And so all those things you have to look into and see. And history taking is very important. One of the couples came and said mother had blindness. So we wanted to know what it is. Then it turned out to be retinitis pigmentosa. So we didn't allow, means we consulted the patient that this risk is there. Then she had gone for IVF and she took the donor egg. Thalassemia, post-bariatric pregnancy, nowadays you're seeing a lot of bariatric surgeries. Then Crohn's disease, recurrent urine infections, HIV, hepatitis B and C, post-tuberculosis pregnancy, skin disease, chickenpox, and also simple, the pruritic papules of the pregnancy can be very problematic for the mother. Alcohol and drug addiction, domestic violence, all these things also are imposing severe risk to the mother and the hospital per se, because we might miss the diagnosis at times. So this is the video. This is the video of this was a torsion of the ovary in a pregnant patient. So this is torsion of the ovary. If I don't take the right decision at the right time, I might lose the ovary. So sometimes heroic measures are needed, definitely with your experience and clinical acumen and investigations. Then ovarian cysts during pregnancy. This is a cobular uterus. So if you have abruption, placenta gets separated. This is how the blood clots seeps into the muscle layers, and the uterus doesn't contract, and the last resort is hysterectomy. This is Beeling suturing, which is done for PPH, which we have done recently. This is appendicitis in pregnancy. So again, if you don't diagnose, it can be problematic. This is unicorn weight uterus. There's nothing much, but yes, you have to diagnose that there is unicorn weight, so that if there is any other measures you can take. Ectopic pregnancy, this is a ruptured ectopic, diagnosed via scan. Video. Yeah. So this is about how we treat the PPH, that is postpartum hemorrhage. The uterus is completely relaxed and it's just bleeding. So this is what I wanted to show, that it's completely lax. Uterus is like a rubber. Yeah. Yes, ma'am, any questions, anything? I'm happy to answer. Please tell me.
Any other questions from the attendee side? You can post the questions in the Q&A session.
So the key message is proper detailed history is important. Making a plan for the pregnancy and involving the multidisciplinary team is very important. And doing the appropriate test, if they come for pre-pregnancy counseling, that will be great, so that you know what is the status of the couple. Anything, ma?
Attendees, you can get answers for all your questions. Any other questions? You can unmute, you can raise your hand so that I will allow you to talk, or else you can post your questions in the Q&A session. And the polls are being launched. The attendees are requested to attend the polls. In the meanwhile, if there is any other questions from the attendee side, you can raise your hands. So we don't have any other questions from the attendee side, ma'am.
Okay, then good luck. If there is anything, they can always post me through Kadir and then we'll try to answer them.
Sure. Thank you for your valuable time, ma'am. Yeah, thank
Thank
you.
you.